Female genital mutilation, or FGM, can be linked to mental health problems as well as physical ones. So it may be up to the healthcare professional who's seeing a woman for a physical health issue to spot the signs of any emotional or psychological distress that could be caused by FGM.
FGM is so diverse, both in the type of procedure, how old someone is when it's undertaken, the context in which it happened. So, there's going to be a very individual response. And there's also some evidence that women can be traumatised by it, including post-traumatic symptoms in terms of memories or flashbacks, reluctance to engage in help-seeking behaviour like having gynecological exams or cervical smears, issues of trust or difficulties with mood or depression. And it can also cause a range of psychosexual difficulties in terms of pain or lack of enjoyment with sex. People can also have FGM and not know that it's been part of their experience, particularly if they're very young. There's often lots of silence, even in families. People may not know that it's happened to them. They may not know that it's happened to their sisters. They may not actually have a conscious memory of it, but then as they become aware of their FGM status, or aware of the implications of that, or aware of problems related to that, it may be actually that trauma or difficulty develops at any point in the lifespan. And obviously there's lots of survivors who have very clear memories, and there's an idea about the trauma continuing from the point of the FGM procedure in a very real and very connected way. Not making any assumptions about the effect of the procedure on someone is the really most important thing to hold in mind, is being open and curious and non-judgmental. It's really important to think about the broader context of safeguarding and risk, and weave that into your consultations as well. And thinking about risk to children, and are there any girls in the family, are there other family members that might have a particular view about FGM, and they can feel like difficult conversations to have.
As a healthcare professional who doesn't specialise in mental health, for instance a GP, a practice nurse or a midwife, it's important to talk to the patient. Ask open and direct questions, but try not to delve too deeply because this can re-traumatise them. So instead, think about referring on to specialist services such as counselling and psychotherapy.
There can be this kind of standoff where a clinician is assuming that a patient will name something if it's difficult, and the patient's assuming that the clinician will ask them something if it's important. And obviously what that can end in is no one talking about it. But also what we know is there's also lots of shame and secrecy and silence about having had FGM. So I think for clinicians to feel able to open up the conversation and to ask, starting the conversation is really important. And once you ask, all kinds of information, or conversations or change can then be possible. Sometimes a barrier to asking is then also a concern about, well, what will I do if I open up the fact that someone's depressed or they've got sexual difficulties?
It's important that you're aware of the mental health services that are available in your area and actually how you refer to them. So these may be NHS services, they may be charities or voluntary organisations who can support the patient who's had FGM.
Good communication between services about continued need for care or support needs that might come up is really important. Individuals' contexts will change, priorities will change in terms of social circumstances, other competing demands. So the ability of people to access help at different points in their lives will vary, as will the type of help that's most appropriate for them. So as ever with clinical care, it's an ongoing continued conversation.